জি ধীমান স্যার, আমরা এখন শুরু করতে পারি।
Respected, respected panelists, teachers, colleagues, and friends, good evening. Today, our topic is CRT, cardiac resynchronization therapy. Today, we have two speakers, two renowned speakers of our hospital. One is Professor Ashok Dotto, who is an intervention cardiologist as well as electrophysiologist. He will be speaking on the main topic. And another speaker is Dr. Isma Tara, who is the registrar of our hospital. And we have a panelist, expert panelist, who did not join yet. He is Dr. Jamil. He is a electrophysiologist and intervention cardiologist of Asghar Ali Hospital, Dhaka. Without any delay, I want to start the program. I first request Dr. Isma Tara, Registered Cardiology Department of our hospital, to share his slide and speak on the topic. Dr. Isma Tara, please.
Thank you, sir. Respected moderator, all panelists and participants, a very good evening to you all. I'm going to present cardiac resynchronization therapy. CRT or cardiac resynchronization therapy is the treatment of heart failure appropriate in the setting of sufficiently depressed LV ejection fraction and electrically desynchronous ventricular function. During the past 2 decades, it has emerged as a safe and efficacious device-based therapy for heart failure patients. It was developed in early 90s and was approved by FDA in 2001. In short, it is the last device-based therapy in advanced heart failure before introduction of left ventricular assist devices and cardiac transplant. When our conduction system is normally functioning, impulses travel equally down the left and right bundles. That results in synchronous left ventricular myocardial activation that occurs from apex to base simultaneously in this septum, which is activated from left to right, and the left ventricular free valve. When this normal pattern is impaired in case of bundle branch block, desynchrony results. It refers to impaired mechanical coordination due to impaired electrical activation of heart muscle. In case of interventricular desynchrony, right ventricle contracts before left ventricle, affects septal contribution to left ventricular stroke volume. Intraventricular desynchrony, when septum contracts before the lateral valve, early contraction is ineffective and late contraction stretches early contracting segments. In atrioventricular desynchrony, normally two atria contracts before two ventricles, but in case of asynchrony, this pattern changes. Mechanical desynchrony is contractile discoordination, and electrical desynchrony is identified by wide ears complex. Besides this, desynchrony may be segmental or global. What are the consequences of desynchrony? It has a lot of consequences. First of all, impaired stroke volume. It worsened mitral insufficiency, prolonged LV isovolumetric events, impaired diastolic filling. All these changes leads to adverse remodeling in the already impaired heart, creating a vicious cycle that perpetuates this process into more advanced heart failure. There's several tools to measure the intensity of desynchrony. Among them, echocardiography is the most important. There are some modalities of echocardiography used to measure the desynchrony. The typical CRT system consists of 4 components: a right atrial pacing lead, 2 ventricular pacing lead, one in the right ventricle and the other for left ventricle, which is inserted through coronary sinus, its lateral or posterior tributaries, and a CRT pulse pacemaker generator. There are 2 types of CRT devices. When CRT gives only pacing function, this is known as CRT-P. But when the CRT system provides ICD protection, this is known as CRT-D. But in both of the cases, basic resynchronization mechanism is essentially similar. CRT-P is usually for patients with advanced heart failure, short life expectancy, non-ischemic cardiomyopathy, severe renal insufficiency or dialysis, other major comorbidities, and patient preference. On the other hand, patient is stable heart failure whose life expectancy is more than 1 year, having ischemic heart disease and their lack of comorbidities. CRT-D is usually for these patients. This picture actually shows for the patient who CRT-P is preferred for non-ischemic cardiomyopathy, patient having short life expectancy that I have mentioned in the previous slide. Now the benefits of CRT. CRT improves symptom, it reverses remodeling, and also there is prognostic benefit. It increases exercise tolerance, decreases shortness of breath, improves NYHA status, and increases quality of life. It improves left ventricular ejection fraction as it synchronizes ventricular contraction. It also decreases LV size, so mitral regurgitation and tricuspid regurgitation also reduces. It reduces frequency of ventricular arrhythmias and the need for ICD therapy. It also improves cardiac output and cardiac index, also reduces pulmonary capillary base pressure, and improves diastolic function. CRT reduces frequency of heart failure hospitalization. It reduces mortality due to heart failure and sudden cardiac death. This picture shows beneficial effect of CRT on ejection fraction. Normally, ejection fraction increases 10 to 20% after CRT implantation. This picture shows when CRT is active and when CRT is not active after implantation. There is visible improvement shown in this picture. With CRT reduces mitral regurgitation significantly. This is evident from this picture. Now, these are the possible mechanism by which CRT is giving beneficial effect. By bringing intraventricular synchrony, CRT increases ejection fraction, cardiac output, increased pulse pressure. All this lead to left ventricular end systolic volume. And it also reduces mitral regurgitation. Due to atrioventricular synchrony, left atrial pressure decreases and LV diastolic filling pressure increases. Due to decrease of LA pressure, left ventricular end diastolic pressure also decreases. And because of interventricular synchrony, increased right ventricular stroke volume, all these changes lead to reverse remodeling. This picture shows the desynchronous electrical activation due to left bundle branch block, and the synchronicity returns after implantation of CRT. This is a normal heart when conduction system is normal. This is when left bundle branch is blocked. And this is after implantation of CRT. CRT is recommended for symptomatic patients with heart failure in sinus rhythm with LV ejection fraction 35%, QRS duration 150 milliseconds, and LVVV QRS morphology despite optimum medical therapy in order to improve symptoms and reduce morbidity and mortality. CRT should also be considered in the above scenario when QRS duration is 130 to 149 milliseconds. In this non-LVVB QRS morphology, CRT should be considered for symptomatic patient with heart failure in sinus rhythm, LV ejection fraction 35%, QRS duration 150 milliseconds, non-LVVB QRS morphology despite optimum medical therapy. In the above scenario, CRT may be considered when QRS duration is 130 to 149 milliseconds. CRT is not indicated in patient with heart failure and QRS duration less than 130 milliseconds without an indication for RV pacing. In patients who are candidates for an ICD and who have CRT indication, implantation of a CRT is recommended. In patients who are candidates for CRT, implantation of a CRT should be considered after individual risk assessment and using shared decision making. In patients with symptomatic atrial fibrillation, uncontrolled heart rate who are candidates for AV junction ablation, respective of QRS duration, CRT, rather than standard RV pacing, should be considered in patients with heart failure with mildly reduced ejection fraction. But in this scenario, if there is heart failure with preserved ejection fraction, then RV pacing should be considered. And CRT may be considered in these cases. Overall response rate is 70%. If there is significant desynchrony, that is LVVB morphology and QRS duration is more than 150 milliseconds. This is the widely used criteria, but only correlates with acute response, not for chronic response. Minimal lateral left ventricular scar, which is detected by MRI or SPECT, it's used to follow the response. Measures of wall desynchrony correlates best with acute and chronic response and adequate coronary sinus anatomy. Approximately 30% of patients meeting current implantation criteria fail to respond to CRT. Studies have revealed that up to 30% of patients with a prolonged QRS duration do not have mechanical desynchrony as assessed by MRI or echo, whereas up to 30% of patients with a normal QRS duration and symptomatic heart failure have evidence of mechanical desynchrony on echo or MRI and could potentially benefit from resynchronization therapy. This picture shows who are the highest responder: wider QRS complex, leg bundle branch block pattern, female gender, non-ischemic cardiomyopathy are the highest responder, and the lowest responder group consists of patients having narrower QRS complex, non-LVVB morphology. Male with ischemic cardiomyopathy is in between. There are some clinical risk factors that I have mentioned earlier. In highest response group, female patient, non-ischemic cardiomyopathy, LVVB, and wide QRS complex, whereas in the low responder group, male patient, ischemic cardiomyopathy, non-LVVB, and narrow QRS complex. This picture shows the factors upon which CRT response depend. Thank you all.
Thank you, Dr. Ismat, for your brief and good presentation on basic concept of CRT. We'll take the question in the last, I think so. This will okay, Dr. Ashok? Professor Ashok?
Yes, sir.
Yes. Now, did Madam join us? Did Madam join us? No. Dr. Jamil did not join us yet. So without any delay, because it will be a long discussion. So the presentation of Dr. Ismatara was very much needful for the students. I think students will have many questions and answers on this topic. Now I'll request Professor Ashok Kumar Datta, who will be presenting on cardiac resynchronization therapy. He is the Professor of Cardiology and Electrophysiologist of Department of Cardiology, National Heart Foundation Hospital and Research Institute. Dr. Ashok, now floor is yours.
Thank you, Professor Dhiman Bonik. My respected teachers, moderators, other speaker, Dr. Ismatara, panel of experts, and all the attendees. Good evening. Dr. Spatara has already described the indication of CRT and how it works, how much it is effective. And next, my topic is how to implant the CRT or CRTD. The implantation, before going to the implantation, this is course for basically for the MD students. So I will go very basic regarding this resynchronization therapy, because in depth and very complicated things usually not asked in the examination. The common thing that are asked in the examinations related to CRT-D or CRT-P is, what is resynchronization therapy? Sometimes simple definition may be asked. What is desynchronization therapy? What are the indication already been described? What are the contraindications? Sometimes asked, what are the contraindication? Smatra already described. On contraindication is the narrow QRS complex, less than 130 millisecond QRS complex, number one. Other complication, if you see in the indication of CRT, if the patient's longevity is less than 1 year, presumably, if it is less than 1 year, then CRT should not be implanted. So if the very much moribund patient and life expectancy is less than 1 year, that is also contraindication. So two contraindication that is important. One is narrow QRS complex, other is longevity less than 1 year. Other is the complication and side effect of CRT. I will go through it later on. How will you assess whether the CRT is working or not? That is also important for the follow-up. And most importantly, chest X-ray and ECG. These specimens are given in the examination. ECG of pacemaker as well as CRT, X-ray of pacemaker and CRT. So what is CRT? Simple definition, this is the specialized device therapy for heart failure with poor ejection fraction or ejection fraction with reduced LV, left heart failure with reduced ejection fraction, that usually synchronize the electrical dysynchrony of the patient. It works by electrical synchronization, thereby mechanical synchronization of the heart. And this mechanical synchronization includes atrioventricular synchronization, LV to RV synchronization, and interventricular, means LV synchronization itself. What are the steps of the implantation? This is the pre-procedural checkup. One is informed written consent. Baseline investigation all includes, as usual for other cath lab procedure. And here two things is important. One is NT-proBNP and INR. NT-proBNP, that indicates how much the patient's failure status is. And INR is important because many patients candidate for CRT either have got coronary artery disease, maybe patient with bypass surgery, maybe patient with stent implantation, they may be on the dual antiplatelet therapy, and sometimes patient with valvular heart disease having the valve replacement may be on warfarin. So INR is important in that group of patient who has on artificial valves. Then a patient should be nothing per oral for at least 4 to 6 hours, and proper hydration is also important. This is also important not only for CRT but also pacemaker and other patients. But overhydration is not justifiable. Proper hydration, because if the patient is dehydrated, sometimes we feel when we used to do the pacemaker at afternoon or at evening, we feel very much difficult in puncturing the subclavian or axillary vein because patient is hydrated. When the patient lie down, all the vein collapse. There is minimal flow in the vein. There is low right atrial pressure. So venous puncture become difficult. In this group of patients, proper hydration make the vein a bit more dilated and puncture become difficult, subclavian or axillary vein puncture. Then patient should be sent to the catheterization laboratory at least 30 minutes before the scheduled procedure. Medication charge is important. Sometimes it is asked. If the patient is dual antiplatelet therapy, what you will do? If the patient is anticoagulant, if the patient is warfarin, how long you will stop warfarin. So warfarin should be stopped 5 to 7 days if the patient is anticoagulation is essential for prosthetic valve. That should be overlapped with the low molecular weight heparin or regular heparin. And for any procedure like pacemaker or CRT, INR should be less than 1.5. Patient in cath lab, cleaning and draping of the left side of the chest is important. Conscious sedation and local anesthesia usually given. Subclavian axillary vein puncture and sometimes cephalic vein cut down is done. Incision and preparation of the pocket. Preparation of the pocket on the left side. Usually we used to do on the left side, but sometimes we use on the right side in special situation. This axillary vein puncture or subclavian vein puncture usually done, may be done before incision and pocket preparation, or some operator used to do the incision and pocket preparation, then subsequently do the axillary vein or subclavian puncture. There are advantages, disadvantages of this axillary vein puncture as well as subclavian vein puncture, but cephalic vein cut down is always preferable, especially for RV lead, because this is a very safe way that usually does not produce lead fracture. Then right atrial and RV lead are implanted in the fashion that is usually done like that in pacemaker. In the last session, Dr. Nasiruddin Ahmed already described it. And LV lead typically targeted in the posterior or lateral tributary of the coronary sinus on the epicardial surface of the heart, require use of a specialized delivery system. Sometimes it is asked where the LV lead in the examination, where the LV lead is put. LV lead not within the LV, because within the LV lead is not stable. There is less papillary mass, trabulation is less in the LV, and there is chance of thromboembolism. So LV lead is placed on the outer surface of the LV, that is the epicardium of the LV in the coronary sinus, either in the posterior, posterolateral, or lateral tributary of the coronary sinus. Whether the CAG and temporary pacemaker is essential for all the patients. CAG is usually done at the same setting or prior to evaluate the coronary artery disease, and also to see the coronary sinus anatomy and to see the tributaries where we usually put the LV lead. And temporary pacemaker, not always needed except in sick sinus syndrome. But always be careful, because during RV lead manipulation, RV lead placement, injury to the right bundle branch may produce the complete heart block. So this is the case of CRT implantation. Usually 3 puncture is done on the left side. You see 2 puncture with 2 short wire, other puncture having the CS sheath, that is the 9 French sheath. That is a very large bolt sheath, 9 French sheath with, this is the Amplas catheter inside, and in place of for cannulation, Amplas catheter, sometimes right coronary catheter or multipurpose catheter is used with the help of, usually with the help of Terumo guide wire, Terumo wire, but sometimes PTCA wire is used. Here we use the PTCA wire. This is the sheath for coronary cannulation. This is the Amplas catheter within the sheath, and through the Amplas catheter, this is the PTCA wire to the coronary sinus and posterolateral tributary of the coronary sinus. So with the help of this coronary wire and with the help of this Amplas catheter, sheath is inserted into the coronary sinus. Sheath is inserted into the coronary sinus, through which subsequently we take the left ventricular lead. Which lead is placed first, sometimes asked. Usually we place the left ventricular lead first, then right ventricular lead, and lastly the right atrial lead. But sometimes RV lead is placed first, then the LV lead, And lastly, the right atrial lead. This is the usual way we used to do the CRT resynchronization therapy. So this is the LV lead. Sometimes it is that asked LV lead, how it works. If you see LV lead, there are 4 poles, 1, 2, 3, and 4 poles. This is actually the screwing lead. So this is the screw, not the, so this is called quadripolar lead. So pacing can be done at the tip. Pacing can be done through this pole, this lead, or through this pole. So this is the typical coronary anatomy. So if you see, this is the typical coronary anatomy. So this is the coronary sinus. This is the posterior vein. This is the lateral vein. We have put the lead inside the lateral vein. So lateral wall. Lateral wall, proximal third or middle third of the ventricle is the better side. This is the anterior or great cardiac vein. So this is the lead in the lateral coronary sinus. Then right ventricular lead and subsequently the right atrial lead is placed. So this is the AP view and this is the lateral view. And the tip of the RV and tip of the LV, this distance, more the distance, more the effective resynchronization will be there. So how do you know CRT is effectively working or not? It may be asked. Immediately on table ECG and blood pressure. ECG will show the narrow QRS complex. Blood pressure will be rise immediately. 5 to 10 millimeter blood pressure will be rise when synchronization is done with ECG. Early in hospital, ECG, symptoms and blood pressure. And late after 3 months, symptoms, ECG and echo. Echo will not show the increased ejection fraction. It may take 3 to 6 months to improve the ejection fraction. So this is immediately on table. With the resynchronization, blood pressure increases about 10-15 millimeters. So this is the immediately you can assess the CRT is working or not, and complex will become narrow. So clinically, how will you assess? Clinically, symptomatic improvement from CCS class 4 to class 3, even class 2. ECG will show narrow QRS complex. In place of LVB, there will be RVB pattern or a similar pattern. RAS in lead on and AVR. Echocardiographically improved synchronized contraction of the LV and RV, improvement of the ejection fraction, maybe 25 to 30%. This is the absolute increase in 25 to 30 that indicates out of 100, it is 20%. Out of 100, it is 20% improvement of the ejection fraction and stroke volume output, thereby cardiac output. So that is 20% means huge. If the cardiac output was 3 liters previously, it will improve to 3.6 or 3.75 liter per minute. So reduction of the MR because of synchronization and reduced LV internal diameter. Immediate improvement of the blood pressure during implantation and narrowing of the QRS complex within the cath lab monitor. This is an immediate assessment that is very important. So if the LV lead is placed over here on the lateral surface, so lead on AVL is here, inferior lead is here, anterior lead is anterior. So LV lead, if it depolarizes the LV lateral wall first, then depolarization will go towards the right, anteriorly and inferiorly. This is the axis. Axis of the depolarization of the LV will be changed. That will go from the lateral towards anterior and inferior. So in the lead V1, V2, there will be positive R wave. 2, 3 AVF, there will be positive R wave. So how the ECG will look in CRT? 1 to 2 pacing spike will be there in before QRS complex. If there is simultaneously both ventricle is spaced, there will be single spike because LV and RV pacing happens simultaneously. If there is sequential, means LV pacing is 10 to 40 millisecond before the RV pacing, there will be sequentially two spikes. First spike is by LV, second spike after 10 millisecond or 20 or 30 millisecond RV. So this sequential or simultaneous, that is machine, that means pacemaker or CRT machine itself automatically that can adjust or manually that can adjust so that narrowest QRS complex we can find. If it is seen that with simultaneous biventricular pacing, narrow complex, it should be kept like this. If we see that 10 millisecond sequential QRS complex get on 20 millisecond, that it should be kept there. If it is seen that on 20, to get the on 20 or 110 millisecond QRS complex, 20 or 30 millisecond delay of the RV pacing is essential, that should be kept like this. Pacing spike before POF may be present or not, if the ATI is paced or not. So lead on an AVL, there will be QOF or QR complex. In V1, V2, there will be positive QRS complex and axis should be right axis deviation rather than left or normal axis. So these are the three criteria that indicates the ECG is of the CRT is good and CRT is working. But negative complex in lead V1, QRS axis in other quadrant, and lack of QF in the lead on AVL did not necessarily indicate there is problem in the CRT. I will show some ECG that will show each ECG has got its own pattern, but all cases, that was our own patient, all patients are doing well. So this is the LVB pattern of ECG before implantation of the CRT. This is after implantation. This is the typical ECG, not our patient. Lead on and AVL, there will be QF. There will be positive wave or R wave in the V1, V2, usually because of lateral wall depolarization that moves towards the V1. And as the lateral wall depolarization moves towards right and inferior, so inferior lead, there will be positive. So 2, 3 AVF is positive. This is the typical, but this is present only in 50% cases of CRT implantation, but still the CRT is quite effective. So this is another ECG. There is negative complex in the lead on AVL. There is positive R wave in the V1, V2, but here you see 2, 3 AVF, there is negative complex. Why 2, 3 AVF negative complex? Because the LV lead is on the inferior surface, not necessarily on the lateral surface. So inferior surface is depolarized first, so axis become superior. So here the axis becomes superior and inferior lead is negative because inferior surface is depolarized first. This is another ECG that shows here like a RBB pattern, but this is also effectively working CRTP. This is our ECG that shows, usually in the exam, the ECG, if it is given, that shows the spike that is obvious. Larger the spike, that indicates the higher voltage is used, so more energy is consumed, or that is the unipolar light working. So this is another ECG. So you see, all the ECG are different. So the thing that is asked here, you see there are some lead, there are 2 spikes. Here you will see there are 2 spikes, one for the LV, then next on for the RV spike. Before the POF, there is no spike. So this is the own rhythm for POF. This is another ECG that is different from the previous one. So this is another ECG. Complex looks like normal, but if you see here, there is a spike here. And first, there is negative reflection in lead on and AVL. So that indicates the lateral lead and lateral wall of the LV is depolarizing fast. So this is another ECG, very recent, LVB before doing the CRT. QRS complex is around 170 milliseconds. Ejection fraction was 25 to 30%. So this is after doing the CRT. There you see there is positive complex in the lead on and AVL, but the ejection fraction improved to 35, 36 after doing. There is a small R wave here. So that is not typical for CRT on the lateral lead, but the patient responded well. So this is the X-ray sometimes given. This is the X-ray of dual. This is the double chamber pacemaker. This is the ECG that shows there are 3 leads are here, and 3 leads, one lead in the RV, other lead, if you so closely, there is LV inferior surface, not on the lateral surface. There is LV, multiple pole, that is the quadrupole, multiple pole. That this is another atypical site of CRT that is close to the apex, but patient responded well. And this is the coil for CRTD, that is called shock coil. That is the shocking coil. That is the superior vena cava coil. This is the RV coil. Sometimes SBC coil may not be present, and this is the RV coil. If the RV coil or superior vena cava coil or both coils are present, that indicates the machine is CRTD, not CRTP. Both are CRTD. And if there is no coil here, that indicates it is CRTP, only pacing. So this is interesting. This is the ICD, single chamber ICD. Initially that was put on the left side. After battery depletion, we saw that this left subclavian vein is totally occluded. So we put on right side. Here, right side, there is no SBC coil, but there is RV coil. So ICD may be only on coil, that is RV. That has got advantage because that rarely produces the obstruction of the superior vena cava, obstruction of the subclavian vein. Sort of the complication. Sometimes are sort of the common complication. Commonest complication is the pain and hematoma. Rare complication is pneumothorax, but very much dangerous complication and life-threatening complication. One is pneumothorax. Air embolism frequently happens, but usually in absence of cardiac decompromisation, that does not produce problem because that is filtered by the lungs. Cardiac perforation and other things sometimes happens during puncture, either subclavian or axillary artery puncture. Only artery puncture is not so much dangerous, but after puncturing the artery, if you put the sheath inside, that is dangerous and life-threatening. All of the complication, I will not go details because in pacemaker implantation, the same complication may happen. And with this, I like to thanks. And I think any question is there, we can discuss about it.
Thank you, Dr. Ashok, for your brilliant presentation on CRT, P and D. First of all, I want to, is Madam is there?
Jamil bhai asken mone.
Yes, Dr. Jamil has joined. Dr. Jamil is the electrophysiologist and intervention cardiologist of Asghar Ali Hospital, Dhaka. Dr. Jamil?
Yes.
Yes, Dr. Jamil, my old friend. How are you?
I'm fine. How are you?
Do you have any comments regarding the 2 lectures of Dr. Ismatara and Dr. Ashok, or any questions to our students?
The lecture of Dr. Ismatara.
I think Jamil bhai, just on minute.
Traffic today.
Afsar Sahib, আপনি মনে হয় আমাদের স্টুডেন্ট যারা আছে তাদেরকে আনমিউট করে দিতে পারেন। If they have got any question, they can discuss with it. তাই না?
Definitely, sir.
Thank you. হ্যাঁ, জামিল
সেটা
ভাই,
ভালো হবে।
Thank you.
I missed the
Students
first
and also the registered and fellows. Also the registered and fellows. Dr. Mr. Asfar Sahib.
স্যার শুনতে পাচ্ছি, আমি সবাইকে কথা বলার পারমিশন দিয়ে
হ্যাঁ,
রাখছি।
জি, জি,
কাইন্ডলি
জি,
কারো
জি।
কোনো কোয়েরি থাকলে কাইন্ডলি
হ্যাঁ।
আনমিউট করে আপনাদের কোশ্চেনটা করতে পারেন।
Yes.
Niman, sorry that I'm late today due to bad traffic. It took more than 1.5 hours from Asghar Ali to reach my home. I missed the first lecture. I could follow the Ashok's 2/3 of the last phase of his lecture. He covered, so far I could see, he covered most of the thing for CRTD and CRTP implantation. And nothing much to say. Regarding the puncture, I prefer regarding the vascular access, I prefer puncture method, though the cephalic venous cut down method is the safest method for any device implantation, but it is time consuming. I prefer puncture, and I do axillary puncture, that is extrathoracic, and it has minimum complication of vascular access. Subclavian puncture, it causes lead fracture, especially if these leads are stout, like the RV lead in ICD and CRTD. What technique I prefer, I do 2 axillary puncture for RV and RA lead, and as the ventricular lead is thinner, I go for subclavian puncture of the same side. So that gives comfort to manipulate the leads within a single vessel, 3 leads. And again, regarding placing the left ventricular lead, echocardiography might guide us, especially the tissue Doppler echo, that which part of the left ventricle depolarizes lastly, that is late depolarization of the left ventricular lateral wall. Usually it's near to the atrioventricular groove on the lateral side. So we target for the lateral, not the terminal tributaries of the coronary sinus, but the lateral most tributary of the coronary sinus. And as because if we go for the terminal tributary, it lies very near to the left phrenic nerve, and it causes diaphragmatic irritation and contraction. So we try to find out which part of the ventricle is latest depolarized and select a vein near to that one. So it gives much more wider range of coverage of the from the RV lead. And RV lead usually should be at the apex. And so it makes a triangle, the can of the device, the superior vena cava coil, and the RV coil. So it covers the whole heart when it defibrillates. So that is the idea. And synchronization, for synchronization, LV lead should face first, then the RV lead, then, and in the modern device, and the programmer has the software to tell us that which how much should be the delay between the LV and RV lead. That gives narrower complex and improved response to the CRT and CRT-D. Again, another thing is regarding I've forgotten at this moment the point. That's all. If I can remember, I'll tell it.
Okay, there are some, thank you, Dr. Jamil, for your nice discussion on this topic. There is a question in the chat box. Dr. Nazmun Naila has asked, what device are given, what advices are given to patients with CRTD and CRTDP, patients on discharge? Dr. Ashok, please.
Yes. So the advice that is given to the patient with CRTD or CRTP, that all the advice that is given to the standard pacemaker regarding the movement of the left hand and lying down on the left side, that should better to avoid 1 to 2 weeks. Movement of the left hand, especially to raise the left hand above the head, because sometimes that may produce displacement of the RP, and especially in case of CRTP, left ventricular lead. So movement of the left hand should be restricted for 1 month, but total restriction is not advisable because many patient comes with frozen shoulder on the left side. So better to restrict the hand for 1 week, then he can move the hand, but should not put the hand or raise the hand above the head. This is one thing. Other thing is the all medication. Regarding all medication, sometimes many patients stop all medication after putting the device. That should be given. And regarding whether the patient feeling bad or feeling better, that should be advised regarding how he is feeling, and especially in D device regarding shock, how the patient will feel, what he will feel, how he will understand that machine is going to give the shock. That should be advised properly. That is very important. If the patient make noise, patient should be advised that you should be on seated or lie down in a very safe place, because after giving shock, the patient usually become unconscious for the time being. So that is very important. And regarding journey, first 1 month should avoid the journey, especially that is unsafe, like rickshaw or motorcycle, where if the device shock the patient, patient may fall in a very fatal condition. So these are the general advice or special advice for the CRTD or CRTP patient.
Okay, I have some important points for the students to be clarified. For the students, not the question for the panelist or to Dr. Ashok. Number one is students should be too much attentive in this topic, as because you should be clear about the what is CRTD and what is CRTP. One is cardiac resynchronization therapy pacemaker, and one is cardiac resynchronization therapy with defibrillator. There are different indications of this. Dr. Ismatara has been described it. Any points regarding these indications can be clarified by Dr. Ashok. This is a very important question in final part MD exam.
Yes, very important. Thank you, Dhimandar. In the X-ray, first thing in the X-ray, how will you, in ECG, you cannot say this is the CRTP or CRTD, but in X-ray, you can definitively say this is the CRTP or CRTD. If you see there is shocking coil on the RP lead, either within the RP or in the SBC, both coil may be there, or sometimes only the RP coil is there, because SBC coil is avoided, that may produce the Vena-Cabal syndrome. So presence of coil indicate that there is shocking coil. So that is the either ICD or CRTD.
Yes.
If there is two lead only, on in the right ventricle, on in the right atrium, that is the ICD, dual chamber ICD.
Yes.
On, if there is only on lead with shocking coil, that is the single chamber ICD, as I have shown on picture. So if there is D, there will be defibrillation coil is there. If there is no coil, but there is 3 lead are there, including the যেটা LV lead, যেটা আমি বাংলায় বলি LV lead যে not দেখা যায়, এটা যদি দেখা যায় ডেফিনিটিভলি ক্লোজলি দেখবে, দেখে যদি মনে হয় যে না LV আছে, সেটা লেটারাল ওয়াল হতে পারে, ইনফেরিয়র ওয়াল হতে পারে, অনেক সময় দেখা যায় একটু অ্যাটিপিক্যাল পজিশনে হতে পারে, দ্যাট ইজ দ্য LV lead. That is the CRTP in absence of coil. CRTP patient jeta, all the indications of CRTP and CRTD are more or less same. এখানে আরেকটা যেটা ইম্পর্টেন্ট, ICD usually indicated একটা হচ্ছে primary prevention of the sudden cardiac arrest or secondary prevention. For secondary prevention, if any patient having the history of syncope or having the history of cardiac arrest, he or she is the candidate for CRTD. That is for secondary prevention. If the patient has got ischemic cardiomyopathy, there is a lot of ischemia, that is the source of arrhythmia. These patients are the candidate for CRTD. If the patient has got non-ischemic dilated cardiopathy, cardiomyopathy, that most likely the candidate for CRTP only, CRTP only. So CRTD is indicated if the patient has got high risk for sudden cardiac arrest, like ischemic heart disease, lot of fibrosis in the LV, history of sudden cardiac arrest before, that are the candidate for CRTP. And sometimes it is asked, if the patient has got 6 sinus syndrome, ejection fraction is reduced, 40 to 50% ejection fraction, how will you do? Dual chamber pacemaker or CRTP? So if you go through the ESC newer guideline, if the patient has got less than 40% ejection fraction, patient need pacemaker due to other reasons, 6 sinus, complete heart block like this. This is the class on indication for CRTP. CRTP. If the ejection fraction is reduced, 40 to 50, mid-range ejection fraction sometimes we call, heart failure with mid-range ejection fraction, patient need pacemaker because of 6 sinus syndrome, complete heart block, or some other reason. This patient class 2A indication for CRTP, because if you give dual chamber pacemaker, right ventricular pacing, sometimes failure will be aggravated. RV dysfunction, LV dysfunction over a period of time. So this group of patients should be advised for CRTP rather than dual chamber pacemaker. Thank you, Dhimanda.
Dr. Jamil, any comments regarding this? Or Nessa sir, any comments regarding this?
Dhimanda,
Ji.
thank you, Professor Professor Ashok, for your brilliant and very nicely and precisely you point out all the points, and a very nice lecture you have delivered. And one thing I just mentioned, for placing the SBC coil, especially when you use 2 coil for ICD, don't place the SBC coil into the RA, right atrium, as because
Yes.
if the SBC coil is placed in the RA, just a part of the RA, in that case, point shock is applied, patient may develop atrial fibrillation, and which maybe some sorts of demerits for the placement of the SBC coil. So be assured that is SBC coil is placed in the SBC, not in the RA. It's an important issue.
Very important.
And sometimes, especially I have one VIP patient, after placing the permanent pacemaker for his complete heart block, he wants to play golf. এগুলো কিন্তু প্রাইভেটলি খুব ইম্পর্টেন্ট ইস্যু। আমাকে অনেক কিছু ক্ষেত্রে দেখছে তাকে কোনোভাবেই বিব্রত করা যাচ্ছে না যে স্যার আপনি এই মুহূর্তে গল্ফ খেলতে যাবেন না, আপনি যাবেন না। এবং আলটিমেটলি সে পেশেন্ট ইন্ডিয়া পর্যন্ত গেছে তার গল্ফ খেলার অনুমতি আনার জন্য। হ্যাঁ, তো এইসব ক্ষেত্রে যদিও স্ট্রিক্টলি মানে ইয়ে নয়, তবে অ্যাটলিস্ট 1 to 1.5 years, অ্যাটলিস্ট 1.5 বছর, 1 থেকে 1.5 বছর আমাদের একটু রেস্ট্রিকশন রাখা উচিত, যে খুবই মানে হাইপার এক্সটেনশন কোনো মুভমেন্ট, আর্ম মুভমেন্ট গুলো যাতে অ্যাভয়েড করা যায়, স্পেশালি ফর পেসমেকার ইনফেকশন। আর সিআরটি ক্ষেত্রে তো এই ধরনের সাধারণত গল্ফ খেলার অনুমতি আমরা সাধারণত এরকম ইয়ে দিই না এগুলো। এবং রিগার্ডিং ড্রাইভিং স্পেশালি ফর দি পার্মানেন্ট পেসমেকার পেশেন্ট, ফার্স্ট 3 months আমরা অনেক সময় অ্যাভয়েড করি ড্রাইভিং না করার জন্য, এগুলো ইম্পর্টেন্ট। আর অশোক অত্যন্ত সুন্দরভাবে প্রত্যেকটা পয়েন্ট এত সুন্দরভাবে, বিশেষ করে ইসিজি গুলো চেঞ্জ কিভাবে হচ্ছে, তারপরে কোন ইয়েতে, এটা আমরা সত্যি মানে খুব অ্যামেজিং লেকচার ফ্রম ডেলিভার্ড বাই অশোক। ডেফিনেটলি ইটস এ ভেরি গুড লেকচার এবং ভেরি প্রিসাইসলি ও এটা পয়েন্ট আউট করছে। এগুলো যদি আমাদের স্টুডেন্টরা যদি ওর লেকচারটা সুন্দরভাবে শুনে, আবার এটা যদি ওরা একটু প্র্যাকটিস করে, আমার মনে হয় কোনো বই পড়ার দরকার নেই। হ্যাঁ, কোনো বই পড়ার দরকার নেই, কারণ একটা সিআরটি পিএই বা ডি এগুলো খুব বেশি কিছু ধরা হয় না, তো মেইনলি ইন্ডিকেশন গুলো ইয়ে করা হয়, তারপরে প্র্যাকটিক্যাল পয়েন্টের জিনিস করে সেই ক্যাথোলিকে কখন ঢুকছে কিনা এগুলো জানার জন্য। সেসব ক্ষেত্রে এই ইম্পর্টেন্ট পয়েন্ট গুলো, যে কোথায় লিড দিয়ে, কোন ভেইনে দিয়ে, কোন ট্রেভিটারি দিয়ে দিচ্ছে, কোন কয়েল কোথায় প্লেস করা হচ্ছে, এইগুলো একটু জানা দরকার।
এই স্টুডেন্টদের জন্য আমার একটা ইম্পর্টেন্ট কোশ্চেন আছে, এই যে এটা মানে স্টুডেন্টদের জানা লাগবে পরীক্ষার জন্য, যে লেফট ভেন্ট্রিকুলার পেসিং লিডটা তো করোনারি সাইনাসে দেওয়া হয়। আমি একটু বাংলাই বলতেছি, যে লেফট ভেন্ট্রিকুলার লিডটা করোনারি সাইনাসে দেওয়া হয়। তো করোনারি সাইনাসটা কোন ভিউতে দেখা হয় অ্যানজিওগ্রামে, মানে ক্যাথ ল্যাবে, এটা খুবই
খুব
ইম্পর্টেন্ট
ইম্পর্টেন্ট,
কোশ্চেন
খুব ইম্পর্টেন্ট।
এবং আমাদের সময় কন্টিনিউ একজন সিআরটি ধরলে এই কোশ্চেনটা করা হইতো। এটা একটা কোশ্চেন। এবং করোনারি সাইনাসের 5টা ব্রাঞ্চ আছে, কোন ব্রাঞ্চে আমি লিডটা প্রেস করব, এটা কিভাবে আইডেন্টিফাই করা যায়? ডক্টর অশোক or the panelist, Dr. Jamil or Dr. Professor Nassar?
হ্যাঁ বলেন যে কেউ এনিওয়ান।
বলেন, এটা বলতে হচ্ছে।
আরেকটা কোশ্চেন, দিস ইজ
আমাদের
এই সময়ের
প্রশ্নটা
জন্য
সত্যি
আরেকটা কোশ্চেন অনেক সময় ধরে, জামিল ভাই অথবা নেসার ভাই বলেন, অনেক সময় ধরে যে দিস ইজ রিসিনক্রোনাইজেশন থেরাপি। খুব ভালো করলে অনেকে বলতে পারে যে হঠাৎ আদার রিসিনক্রোনাইজেশন। এখন যেহেতু হিজ বান্ডেল পেসিং এবং বান্ডেল ব্রাঞ্চ পেসিং চলে আসছে, এই দুটোর নাম অনেক সময় শুনতে চাই। এটা আর কি। থ্যাংক
ওই
ইউ।
দুটোর নামটা বলে দেন স্টুডেন্টদেরকে। একটা হিজ বান্ডেল ব্লড প্রেসিং, আর
একটা হচ্ছে আইদার দ্য হিজ বান্ডেল পেসিং অথবা রাইট বান্ডেল ব্রাঞ্চ পেসিং আর কি, রাইট
Left bundle branch
এটার উপরে একটা স্ক্রু লিড লাগায় দেওয়া হয়।
left bundle branch spacing
সরি,
is
লেফট
done
বান্ডেল ব্রাঞ্চ
incident-
পেসিং।
yeah.
করোনারি সাইনাসটা কোন ভিউতে দেখবে? ক্লাসিক্যালি একটা ভিউ আছে মনে হয়।
অ্যানজিওগ্রামের ভিউ যদি আপনারা দেখেন, স্টুডেন্টদের বলছি, যে কয়টা ভিউ নেওয়া হয়, দুইটা ভিউ একেবারে ইনিশিয়ালি যেটা আমরা লেভো ফেজের মতোই যেটা যেভাবে নেই করোনারি অ্যানজিওগ্রামের সময়, এপিতে একটা নেই, এলেওক্রেনিয়াল একটা ভিউ নেই, যে ভিউতে করোনারি সাইনাস ভালো দেখা যায়। এবং এলেওক্রেনিয়াল বা লেটারাল, অনেক সময় লেটারাল নেওয়া হয় না, সুতরাং এলেওক্রেনিয়াল এবং এপিকর্ডাল এই দুইটা ভিউ এর জন্য খুব ইম্পর্টেন্ট। এই দুইটা ভিউ, যে কোনটা পোস্টেরিয়র ট্রাবিউটারি, কোনটা লেটারাল ট্রাবিউটারি নাকি পোস্টো লেটারাল ট্রাবিউটারি, এটা দেখার জন্য দুইটা ভিউ, এপিকর্ডাল অ্যান্ড এলোক্রেনিয়াল।
আচ্ছা, নেক্সট হচ্ছে যে আপনার একটা পেশেন্টের এলবিবি আছে এবং ডিউরেশন যেটা বলা হয়েছে 0.13 সেকেন্ডের বেশি, তার ইজেকশন ফ্র্যাকশন লেস দেন 30। নেক্সট কি ইনভেস্টিগেশন করা যাবে যেটা দিয়া তার আমরা বুঝতে পারবো যে তার সিআরটিডি দিলে তার ইমপ্রুভমেন্ট হবে কিনা? এটা কি কোনো ইনভেস্টিগেশন আছে বা নেক্সট কি ইনভেস্টিগেশন প্রসিডিউর, নাকি সবাইকে আমরা বলবো সিআরটিডির জন্য? এটা কিন্তু খুবই কমন কোশ্চেন সাবজেক্ট বায়োর টেবিলে।
Actually, mainly হলো যে সিআরটি তে যারা রেসপন্ড করবে, সিআরটি রেসপন্ডার্স আর মোস্টলি নন ইসকেমিক পেশেন্টস, ডাইলেটেড কার্ডিওমায়োপ্যাথি, ইডিওপ্যাথি, এদের মাসল মাস প্রিজার্ভ থাকে, মাসল থিকনেস প্রিজার্ভ থাকে। নেক্সট ইনভেস্টিগেশন ইজ ইকোকার্ডিওগ্রাফি, দ্যাট হেল্পস টেকিং দ্য ডিসিশন।
নর্মাল কালার ডপলার ইকো অর আদার ইকো?
Color Doppler, including color Doppler with tissue Doppler.
Yes,
Tissue Doppler, that is very
Tissue Doppler.
Tissue Doppler
That gives
imaging, yes.
the way
The
of
answer-
activation of the musculature during echocardiography. That gives color coding is there, so the echocardiographer can see which part is early repolarizing, which part is depolarizing, which part is lately depolarizing. That gives a wonderful decision making where should lead should be placed. Another thing is especially in the ischemic cardiomyopathy, when we take the decision for putting a CRT-P or CRT-D, in that case we look at the lateral wall muscle mass. If the thickness is preserved, contraction is preserved, they respond better than if there is no muscle in the lateral lead where we place the LV lead, as because in the scar tissue pacing gives no synchronization.
yes.
Okay, I have another query for the students, for the student that একটা পেশেন্টকে আপনার যে একটা ইসিজি তে দেখা গেছে যে আমরা যে ডক্টর প্রফেসর অশোক যে ইসিজি গুলো আমাদেরকে দেখাইছেন, ওগুলোতে আমরা দেখছি যে আমরা তো এটাকে ডুয়েল চেম্বার পেসমেকার থেকে কেমনে ডিফারেন্সিয়েট করব? যে অনেকগুলো ইসিজি আছে যে অ্যাট্রিয়াল সেন্সিং ভেন্ট্রিকুলার পেসিং, আমি তো এটা অনেকে পরীক্ষার টেবিলে বলে দিবে যে এটা স্যার ডুয়েল চেম্বার পেসিং, অ্যাট্রিয়াল সেন্সিং ভেন্ট্রিকুলার পেসিং অর ভেন্ট্রিকুলার অ্যাট্রিয়াল। এটা ডিস্টিংগুইশিং ফিচারটা আমার মনে হয় ডক্টর অশোক আরেকবার একটু বা ডক্টর জামিল একটু ক্লিয়ার করে
ডিস্টিংগুইশিং
দিলে
ফিচার আমি যেটা বলি সেটা হলো যে usually CRT-D, CRT-P তে there is no spike before the P wave. Usually it just sense the atrial activity And there will be double spike before the QRS
Yes,
complex.
it is very important. For the student.
So
Double
one
spike
positive,
before
one
the
negative,
QRS
usually
complex.
in most of the leads. So this double spike very narrow timing পরপর হয় এবং এটা খুব কেয়ারফুলি দেখলে এটা বোঝা যায়। That gives the idea that it's
Yes.
biventricular pacing.
Yes.
এটা খুব ইম্পর্টেন্ট। ইউজুয়ালি টিপিক্যাল ইসিজি দেওয়া হয় পরীক্ষায় যাতে দুটো স্পাইক দেখা
Like
যায়,
other way, yes.
কিন্তু প্র্যাকটিক্যালি অনেক সময় কিন্তু এলবি এবং
দেখা যায়
আরবি অনেক সময় সাইমালটেনিয়াসলি পেস করা হয়।
করতে হবে।
সেক্ষেত্রে কিন্তু দুটো স্পাইক নাও বোঝা যেতে পারে এবং স্পাইক এত ছোট থাকে, স্পেশালি যখন যেটা মানে যেটাকে বলে যে আউটপুট যখন খুব কম আউটপুটে যখন পেস করে তখন অনেক সময় স্পাইকও বোঝা যায় না, অথবা ছোট স্পাইক। যখন সিকোয়েন্সিয়াল পেস করে তখন দুইটা স্পাইক আলাদা বোঝা যাবে। যখন সাইমালটেনিয়াসলি এলবি লিড এবং আরবি লিড পেস করবে তখন অনেক সময় নাও পাওয়া যেতে পারে। কিন্তু কোনো ইসিজিতে যদি দেখা যায় লিড অন এভিএল এ কিউ পাওয়া যাচ্ছে এবং ভি অন এ আর পাওয়া যাচ্ছে, সেটা বুঝে নিতে হবে যে এটা কোনোভাবে আরবি লিড, শুধু আরবি পেসিং না। আরবি পেসিং এ কখনো ভি অন এ আর আসবে না। আরবি লিড ইন দ্য ভি অন নেভার প্রডিউস আর ইন দ্য ভি অন, ইম্পসিবল। Number one. The same is true. Lead on AVL never will be positive in RB pacing. Jamil bhai?
হ্যাঁ
একমত।
ঠিক আছে
স্টুডেন্টরা কিন্তু এটা খেয়াল রাখা
RB
লাগবে,
pacing
খুবই ইম্পর্টেন্ট।
it gives QS pattern in V1
Yes.
in RB pacing.
মানে I am talking more, I think so. For the student, another important issue is for by the teachers commonly asked. What is the indication of doing an angiogram before CRT? What is the indication doing an CAG or coronary angiogram before
Indication
CRT?
mostly here to exclude coronary artery disease.
Yes.
If there is coronary critical lesions, that should be looked and treated first.
Yes.
Otherwise, the patient is not going to respond to the CRTD.
Yes.
So it may be that if the revascularization is done, full revascularization, either by PCI or by CAVG surgery, he or she might not require CRTD. Function will improve, the LV size will be reduced, and even ECG also changes with revascularization.
Yes.
First, ischemia should be treated. If
Then
the patient is having recurrent VT, VF, then CRTD or CRTD is indicated in those cases.
আচ্ছা জামিল
And
ভাই,
the
যদি
heart
আমি
failure does
coronary
not improve,
anatomy
then
দেখতে চাই,
only
coronary
CRTD
sinus
may be
anatomy,
given. Pardon?
coronary sinus anatomy যদি দেখতে পাই, because coronary sinus cannulation one of the most difficult part.
Very yes.
So coronary sinus anatomy যদি দেখতে পাই যে coronary sinus অস্টিয়াম ডিরেকশন কোন দিকে আছে, ব্রাঞ্চ কোন দিকে আছে, কোন ব্রাঞ্চ কোথায় আছে, এটা জানার জন্য তো অ্যাঞ্জিওগ্রাম ছাড়া আর কোনো সিস্টেম নাই।
না,
তাহলে তো this is the essential part for before doing the CRT in all patients, whether ischemia or non-ischemic, whether age 25 or 30, that does not matter at all.
For doing angiogram, I differ with Ashok in one point. He said in the same setting, doing angiogram and do the device. We do it for reducing the cost of the patient.
Yes,
But
yes.
ideally, it should be done before planning for a device. As if there is it becomes that there is two coronary critical stenosis, we have to do the PCI first. So it should be done separately, ideally. And another thing, point at that time I have forgotten to mention, that is resynchronization. Resynchronization is done between LVRV and atria to ventricle. All are resynchronized.
All are resynchronized.
Yes, all are good. So from the questions from other panelists or discussion point, any points left?
আরেকটা কোশ্চেন আছে এখানে, how do you differentiate ECG of RV pacemaker from CRT coronary sinus placed in the inferior wall? Dr. Kamrul Hasan, এটা ইম্পর্টেন্ট। RV apex এর পেসিং এ যেটা হবে LVB প্যাটার্ন হবে, no doubt. এবং RV apex, RV inferior wall, inferior lead, there will be negative because the depolarization or pacing started from the inferior wall or RV apex, then it depolarizes upwards and towards the left. As it goes upwards and towards the left, so left-sided lead on AVL, there will be positive, no doubt. If we give in the inferior sinus means inferior wall of the LV. Remember, we are pacing the pacemaker lead in the RV, not the LV. And in case of coronary sinus, whether you put in the inferior wall or lateral wall, that is LV only. So LV lead, LV pacing will produce the right bundle branch pattern or R in V1. Typical RBB or R in V1, at least R in V1. That is important. Inferior lead, there will be negative also. Lead on AVL, there may be positive, but R in V1 indicates that it is depolarizing or it is pacing the LV, whether it is inferior wall, lateral wall, or LV anterior wall.
I think Professor Buddhit Jaman sir is with us. Sir, any questions or any comments, sir? Sir is with us.
No comment actually. Thank you very much. Only thing is that whether we are doing a regular echo evaluation before CRT, why not we are doing echo evaluation? Previously, when first CRTD came, it was mandatory to evaluate the patient echocardiography. So
Yes,
whether this patient is fit for, or whether patient will be benefited for CRTD. But nowadays, the electrophysiologists they are not, they are quite reluctant doing echo evaluation before doing CRTD. What I mean that the indication of CRTD has been relaxed quite a bit from the very beginning. I don't know whether it is scientifically proven or just it is the device-driven indication. I just want to comment from Dr. Ashok and Professor Ashok.
I want to comment on this.
Yes,
Recently,
Yes,
the physicians or the specialists who are doing the CRT, and according to the recent guidelines, for CRT indication, only the echocardiographic LV ejection fraction and the QRS duration is considered. Although we evaluate the dysynchrony by tissue Doppler or strain imaging, but these are not the predictor for responding CRT. Echocardiography can be used for the lead placement. And in that cases, speckle tracking echocardiography with radial strain. So radial strain more than minus 15% will indicate that the tissue can be conjecturally late. So there is viability. So this helps in late placement, but this does not indicate that this tissue will respond after CRT. So for CRT indication, echocardiography is needed to evaluate the LV ejection fraction, and ECG is very important, as already Dr. Smith and Professor Ashok mentioned about the QRS duration. And routine follow-up and follow-up after CRT, echocardiography should be used, as already mentioned, all the points are discussed here.
Okay, thank you to you,
Exactly.
madam.
Exactly.
Okay, thank
Madam,
you.
echocardiography has great importance after optimization of the CRT, because what the used to do, narrowing of the QRS complex, unimportant. Other is VTI, that is very important. Just LV, RV pacing sequentially when the VTI is better, we'll see that stroke volume output is better. So per echo, LV-RV pacing duration or pacing interval is important. So echo is not ignored anyway, but importance of echo is a bit diminished, because what Ismat was showing, 30% of the patient in absence of LVV, electrical desynchronization, there may be mechanical desynchronization. So in this group of patients, though there is echo desynchronization, but ECG is normal, if we put the CRT, that will not actually synchronize the LV mechanically, because there is no electrical desynchronization. So this group of patients, even the echo criteria told you that desynchrony is there, but this group of patients does not respond to the desynchronization therapy. And echo in post-op patient, post-procedure patient is very much important.
Now I want to have some comments from Dr. Habib Bhai is there? Dr. Habib? Yes, I think so. Habib Bhai is there. Habib sir?
There is another question, why CRTP? in non-ischemic cardiomyopathy not use CRTD? I can understand the question.
Yes, I also don't understand the question. Just got given by Dr. Kamrul.
আচ্ছা কামরুল, কোশ্চেনটা হচ্ছে এইরকম যে রিসেন্ট কিছু স্টাডিতে দেখা গেছে, স্পেশালি স্টাডিটার নামটা ভুলে গেছি জামিল ভাই, যেটাতে বলা হচ্ছে যে NIDCM, যেটাকে নন ইসকেমিক ডাইলেটেড কার্ডিওমায়োপ্যাথি, দেখা গেছে যে স্টাডিটা কি নামটা যেন ফিনল্যান্ডের দিকে, ওইদিকে কোথায় হয়েছে, দেখা গেছে যে NIDCM যেটা তাদের ICRTD লাগায় দেখা গেছে ওভার এ পিরিয়ড অফ 3 to 5 years কোনো শক দেয়নি। সেই জন্য বলা হচ্ছে যে NIDCM যারা, তাদের যেহেতু স্কার কম থাকে, চান্স অফ VT-VF is very less. So this group of patient improves with CRTP only. On the other hand, যাদের ischemic cardiomyopathy থাকে, lot of fibrosis, and that is the source of VT and VF. So this group of patient may be benefited from CRTD. In short.
Actually, in non-ischemic cardiomyopathy, if synchronization is done properly, so it causes reduction of the ventricular size. So when the ventricular size reduces and ejection fraction improves, say if it is more than 35% of the ejection fraction becomes more than 35%, the risk of arrhythmia reduces also.
Yes.
So they don't have much VT-VF like ischemic cardiomyopathy, and again resynchronization reduces the chance of arrhythmia more. So CRTP suffices their need.
Okay, thank you, Dr. Jamil. Next, I'll request Dr. Tawfiq Shahriar Haq. Tawfiq Shahriar Haq is with us. Tawfiq, any comment?
Yes, sir. Thank you, sir. Actually, this was a very important lecture. I think every single tips and tricks was discussed in details. I hope the students understood these things. And we need to discuss about CRT more and more with our students and junior doctors, because we actually don't offer CRT to patients who actually really need them, who are suffering from heart failure and there is recurrent hospitalization, probably because the students who will be becoming cardiologists and our junior doctors are not very sure about the what effect a CRT is going to give to the patients. So if we discuss this more and more, they will offer it more, and many of our patients who we deal actually but get a CRTD implanted from abroad because they were not properly briefed, and they didn't find our comments very confident, because different people are presenting it to them in differently. The junior doctors are not sure, the mid-level is plus minus, and we are confident. So the patients actually don't get confidence. If we all speak the same language and tell them about the benefit, and I'm sure we will have more patients taking up CRT from us. Thank you very much, Professor Ashok sir and Dr. Ismat. It was a very interesting lecture. Thank you.
Thank you, Dr. Tawfiq. In this issue, I want to have a silly question for the students. It might be asked. It should be ready for the students before going to the exam. What is the cost of CRTD in our country or in your center? CRTD and CRTD-P, and what is the cost? And it is a very silly question, but it might be asked in the exam. Because Tawfiq has already talked about this should be offered to our students, to our patients. So this should be ready by our students. Next, any comments regarding this? No, I think so. This should be not comments here. Next, any question from Dr. Kalim? Dr. Kalim.
Thank you, sir. This nice presentation by Dr. Ashok sir and Dr. Ismutara. And thank you, Professor Jamil sir, to come in our webinar. And it is a great presentation, Ashok sir.
Yes.
Thank you, sir.
Thank you. I think we are at the end of our today's webinar. It was a long webinar. Late night is and it is 9:20. Dr. Jamil, any ending remarks regarding this presentation or this webinar? Dr. Jamil, my old friend.
Thank you. Thank you, Devan. Actually, every points what is needed for the MD student has been discussed here, and even more than that. And all these things are not needed for their examination. You have rightly placed those questions which are asked in the Vivacy. And this type of symposia should be continued, as because regarding this CRT, CRT-P and CRT-D, ICD less discussed in the general forums of cardiology. These are mostly electrophysiology related, but many generalists do implant ICD and CRT-D, but it needs better follow-up. And after implanting, they just say your work is done, you don't come to me, like that. I have got some patients who are under my follow-up now. So one who implants it should know its follow-up also. Otherwise, the patient suffers. And again, indication what Ashok shown, proper indication and proper selection of patient is very important for responding to the CRT. If the indication is not there and only white QRS complex put the CRT, all patient will not respond, and the patient will suffer and lose their money, as it's expensive devices. So only CRT-P 5 lakhs, 5 lakhs and half. CRT-D it starts from 6 lakhs and half to 9 lakhs. So very expensive. Not all patient can afford, and we don't have reimbursement from the insurance company also, what is available in Western world. So patient choose should be done properly with proper indication, then we'll get the better result and good result with a better response. Thank you very much.
Thank you, Dr. Jamil. Bodhijaman sir, thank you. Sir, can you please end this session?
Oh, thank you very much. Thank you, Dr. Dhiman. It was a great presentation by both the speakers. And thank you, Dr. Jamil, for his very valuable comments. And Dhiman, great moderation. Just before যাওয়ার আগে একটা কথা মনে পড়ে গেল, তাই আবার জামিল ভাইকে জিজ্ঞেস করি। জামিল ভাই,
জি,
সবকিছু আপনি ফলো করলেন, সব ইন্ডিকেশন ফলো করলেন, পারফেক্টলি করলেন, সবকিছু ফলো হলো, ক্লাস 1 ইন্ডিকেশন ভেরি গুড। তারপর নন রেসপন্ডার কত পার্সেন্ট এবং হোয়াই দে আর নট রেসপন্ডিং?
Even then, non-responders are 30%, up to 30%. Up to 30%.
Why they are not responding?
There are some less optimization after device implantation. If carefully optimized with the programmer that has software for optimization, and with the help of echocardiography, what Dr. Tuhin Haq was telling, that helps us for optimization of the CRT response. And with those response, less responding patient number of less responding patient can be reduced. And rest unknown why they are not responding, even with all the maintaining everything.
এখন non-responder percentage is 30%.
Maximum up to
30%. Okay, thank you. With that, I think I should and call an end to this. Essentially, it was a long session, a very interesting session. Thank you, Dr. Jamil, for coming here and join us and have very valuable comments. And thank you, everyone, for joining the session. So,
thank you, sir.
Can close it.
Good night.
Good
night, sir.
Good night.
Good night, everybody.
Assalamu alaikum. Good night.
Good night. Good afternoon.